I would like to introduce factors contributing to the long-term success of dental implant and preventing complication. Contents is composed of implant complication and why implant lost during healing period and why peri-implantitis disease occurred and why implant component problem, screw loosening and fixture fracture is occurred, and how prevent implant loss during healing period, and last I will introduce cases. Implant complication is composed of first implant loss during healing period and peri-implant disease and implant component problem. Implant is lost during healing period like this, and early failure of GBR. This GBR bone graft is infected. As a result, bone graft is resolved, and finally the buccal bone width is decreased. And peri-implant disease is occurred after the surgery. This impacted in the infection in the bone graft side, so we have to do bone graft again, like this. And peri-implant disease make bone resorption around the implant. Implant component could be fractured and screw loose, and implant fixture could be fractured like this. And we have to remove implant with a trephine. Why implant lost during healing period? First, socket inflammation, and second, post-operative infection. Third, subgingival cement toxicity of immediate restoration. Fourth, overload compared to implant insertion torque value. Why occurred peri-implant disease? First, implant design is non-platform switching design, and implant is placed in the supracrestal level of bone. And third, heavy loading force than the implant bearing capacity. And second, bone region, bone factor. The bone have less than 2 mm buccal bone thickness, and the GBR bone graft was failed. And third factor, gingival. The gingival biological width or gingival depth is less than 4 mm high. And second, subgingival cement is remained, and the patient is poor oral hygiene technique. Why implant component problem is and screw loosening and fixture fracture? First, reduce the number of natural occlusal stops. So the heavy force is focused on the implant. And second, heavy occlusal force with parafunctional oral habit make screw loosening and fixture fracture. And off-asis angled implant without splinted restoration could induce the component problem. And fourth, improper prosthetic design. The example is splinting or the over heavy offset axis, cantilever. Fact of contributing to implant failure. First, the patient fact, and second, iatrogenic fact, and local fact, technical fact. Patient fact is composed medical status and diabetes, cigarette, smoking, and age. And iatrogenic factor is overheating of bone during surgery. And second, implant orientation and lack of communication. And third, local factors, peri-implantitis and position of implant site and bone quality and bone continuity and irradiated bone. Technical factor is composed of different implant system and the length of implants and mechanical failure. How prevent implant loss during healing period? How prevent implant loss during healing period? First, socket inflammation and post-operative infection, and subgingival cementosis of immediate restoration and post-low implant ITB. I will introduce these steps prevent method. First, socket inflammation. This implant placed at least 2 weeks after tooth extraction in acute inflammation site. So we have to do define the acute inflammation site. At first, severe tooth mobility, and second, difficult bleeding control after tooth extraction. Third, difficult pain control after anesthesia, and difficult to remove inflammatory granule tissue implanted into bone marrow. Case: this patient have acute peri-implantitis. So extracted number 11, and extracted tooth is splinted with a wire. A wire is attached crown, and root is dissected, and this is splinted with the adjacent tooth, and after 3 weeks, the gingival contour is preserved by the splinted natural tooth. So the circular incision in the socket is done for the cut connection between the gingival and granule tissue. Or connection is cut, and then granule tissue is removed with a spoon or peri-elevator. Yeah, so we can remove well-defined granule tissue with one mass. And then a pointed drill is penetrated into palatal wall, and the tip of a point drill is inserted into bone, and then change this orientation of drill for implant placement axis. So finally, diameter 5 and 40 drill was done, and the implant is inserted into socket. So we have to keep this healing period at least 3 weeks in the acute infection site. So we can, after 3-week healing period, we can remove the granule tissue with one mass without this infection, and we can insert immediate restoration. This remove the tooth is cut in the cingulum site, and the abutment and the tooth is connected with the light curing resin, and so this resin they connect natural tooth and abutment and remove. And there's the gap between abutment and the natural tooth is filled with the light curing resin. And then polish it, adapt it again. I recommend the gingival contour or preservation with natural tools in the incisor tooth roast. This unreacted resin is removed with alcohol sponge, and then abutment is tightened with 35 Newton centimeter torque. So we can preserve gingival contour in extraction socket. So implant the buccal bone width is about 2 millimeters, and the axis is correct. How prevent implant loss during healing period? The second item, is post-operative infection. Yes. Have a tangent-free flap close in large defect site with intra-bone marrow penetration and deep implant placement is a solution. So after bone graft, flap is open, and this graft is infected by oral microorganism. So this bone graft is roasted. The case, this large socket bone graft bone was resolved, and after 3 weeks, this buccal bone is buccal bone was already resolved, and buccal gingiva is collapsed into lingual site. So implant was placed, and then the bone grafted about 3.3 millimeter in vertical height, 10 millimeter defect height from gingival crest to buccal wall. And implant, the inner implant and the PICS connector was connected, and the gap between the implant and the socket is large. The inner cavity was filled in the gap, and the healing cap and the Wi-Fi mesh was connected and primer closed. Suture. And here, this implant, vertical bone height 3.3 millimeter is grafted, and after 2 months, crown was inserted. After 3 months, we checked this socket and the result. The gingival volume was recovered to buccal side, and vertical bone graft was successful. So we have to keep this flap closed during healing period. Even if you use Wi-Fi mesh or healing abutment. So I recommend the tangent-free flap operation. Subgingival cement toxicity of immediate restoration have to be prevented. This isolation of cemented abutment with a Teflon dam or screw retained provisional restoration. So this cement is infiltrated to socket. So this cement toxicity made inflammation in the bone, socket bone, like this. Teflon or lava is punched, and abutment is inserted into hole, and gingiva is retracted on the abutmental margin, and you insert provisional restoration, and remove cement. And then remove this Teflon then. Yes, we can remove cement. And screw retained restoration, patient. This I extracted number 11 and 12, and two implant is inserted. First implant drill and the bone graft. Finally implant is placed. Prognosis. Yes, the bone quality is hard, so immediate loading surgery. Implant drill. After extraction, bone drill is inserted in number 22 and 12, and diameter 2.2 is penetrated into palatal wall. And this socket was mild infection, not acute inflammation. So we can do immediate implant placement with extraction. So there is no excessive bleeding because there less infection. If acute infection, you cannot control the bleeding. And finally, diameter 5 drill was penetrated into palatal wall, and incision and flap. Now, circular incision is done in buccal distance. There was no buccal bone, and so the blade cut the granulate tissue between the bone and the flap. All gray tissue is removed, and the depth was 8 mm from the gingival to buccal bone, and grafted. Buccal bone defect. So I would like to recommend allodum on buccal defect at first, because this gingival width was reduced because of inflammation. So increase this dermis, and then bone grafted, and implant is placed in the graft site. Already, so palatal wall is penetrated with the drill, and implant is placed. And you have to check gingival depth about 4 or 5 mm. So we can identify this drill depth, implant depth. So picture driver have depth guideline, and then impression code. Bite impression copying is connected, and the temporary bridge cell is connected with the bite impression copying with the right curing resin, and then this connection connected with the two components. And then emergence profile is made by right curing resin, and gap between abutment and shell, temporary bridge cell and screw try in, check it. So at the result of surgery, like this. We don't use cement, so there is no cement toxicity and inflammation. So I recommend screw type provisional restoration with immediate loading, and remove restoration after 2 or 1 month. You can find this emergence profile like this. So bite impression copying is inserted and impressive. Now I use intraoral scanner. So I don't now I don't make the stone model. Now intraoral scanner is correct than conventional impression technique. But here we connect analog and insert. Cornea bridge is inserted after 3 weeks. Screw retainers restoration is inserted. Here, this actually within 1 month, this restoration was inserted after surgery. So, pause. Low implant insert torque have to be prevented by submerged implant placement without provisional restoration or healing abutment. And we have to do use compressive implant placement. I recommend that this criteria. If you want immediate restoration, ITV have to be over 40 Newton centimeter. And if you just ITV value is only 25 Newton centimeter, I recommend the diameter of 4.5 healing abutment. But as over ITB over 40 Newton centimeter, the healing abutment diameter could be used about 4.5 or 7.5 healing abutment. But ITB is over only 25 Newton centimeter. This healing diameter have to be limited to 4.5 or 5.5, like conventional healing abutment. And here, if in the maxilla molar, the ITB of 40 Newton centimeter, you can connect the diameter 7 healing abutment. So, but ITB was of 25 Newton centimeter. You have to use conventional healing abutment. So ITB is very important, but the bone quality is lower, especially in the upper molar. So you have, in this case, you have to connect conventional diameter 4 or 5 healing abutment in the ITB of 25 Newton centimeter. But if under ITB under 25 Newton centimeter, so I recommend it's cover screw or this just crystal levels conventional healing abutment length. So we have to do compressive implant placement in the maxilla molar with the weak bone and first the point initial and final diameter 4 final drill and then diameter 5 implant have to be inserted for get initial stability. So in this case, you have 40 Newton centimeter ITB, but you have to think this bone quality will be decreased during 6 weeks. So you have to use conventional healing abutment diameter 4 or 5 because without conventional, without compressive implant placement, so you get, if you get 40 Newton centimeter ITB, so you can connect diameter 8.5 or 7.5 healing abutment. But if you use the compressive implant placement, you get even you get 40 Newton centimeter ITB. So you have this ITB will be decreased during 6 weeks. So you have to use conventional diameter healing abutment. In insertion socket in maxilla, so the remainder bone height is limited into 2 or 3 millimeters. In this case, you have to use compressive implant placement. So diameter 4 drill is the final drills, and then diameter 5 fixture is placed into remainder bone. And in the molar, molar bone quality is usually dense. So final drill is a diameter 4.5, but implant is diameter 5. Implant is inserted. You can get about over 35 Newton centimeter with this technique. Insertion socket. This socket is osteomyelitis remove the bone marrow bone. So this bone marrow was empty. So only diameter 5 drill was done, and diameter 6 implant was placed for compressive implant placement, and then bone grafted. And the gingival thickness was decreased, narrow. So for thick gingival thickness, I inserted flagen PRF graft on the plate. In shallow sinus, remainder bone height is 2 or 3 millimeter case. So we have to do compressive implant placement. But cortical bone is slightly dense. So final drill is 4.5 for the diameter 5 implant. This remainder bone height is about 3 millimeter. So point drill, and then a 2.2 drill is done in the remainder bone and remove. And diameter 4 implant drill penetrated only 2 or 3 millimeter. And then sinus bone graft was done. And diameter 5 implant was placed. So we could get initial stability. How solve peri-implant disease? The prevalence of peri-implant disease is occurred about 60 and 60 to 80%. Treatment plan of peri-implant disease. First, we have to distinguish this implant have platform switching design and buccal-lingual position and subcrestal placement level are the satisfied acceptable tissue regeneration. If not matched, fixture replacement is decided. Tissue regeneration with the GBR case. So this implant design is a platform switching implant, and implant placement level is optimal. And the buccal-lingual position, especially buccal bone widths, have 2 millimeters. So we can do tissue regeneration. So bone grafted and wait, and then we followed about 7 years, 2 months. So bone has remained. There was no marginal bone change after GBR. There was no buccal bone, so we have to decide GBR or implant replacement. So I checked the implant design. The design was sufficient because platform switching, and placement level was just the crestal bone level, and there was no buccal bone. But I checked that this position is central incisor. So I can use anterior nasal spine eminence for the bone graft support. And I inserted the bone graft, and to prevent the volume collapse, I inserted the Wi-Fi mesh and then closed through tunnel flap. And 12 weeks after the graft, the mesh was removed. And I checked it 1 year, 7 months. The buccal bone was regenerated and maintained. So this GBR was successful. And implant and replacement indication. Non-platform switching design implant have to be removed, and buccal-lingual position out from bone housing. Supracrestal placement level, picture was fractured. In this case, have to be a picture replacement case. We have to do a new trapping kit. So we have inner diameter 4 and 4.5 and 5. So we can remove diameter 4 or 4.5 and to 5 millimeter diameter implant used with the trapine. Like this. This number 26 side implant is fractured. So this remained the implant part have to be trapine. Here, apical 2 or 3 millimeter is remained in maxilla. Maxilla bone quality is soft. So picture over top, remove the picture, and the implant side is slightly tilted to the plantar side, and here trapine. Trapine have to be waved for efficient trapping bone, and then bombard healing armor is connected. and the overtalk is remove implant. Here, about 3 millimeter is fractured and drilled into palatal side bone. And the implant is placed into palatal wall. Pre-operative or post-operative. So this fractured implant don't have inflammation, only chronic grave tissue. So we can insert the implant immediately after removal of remained fragment. So this. The peri-implantitis is extended to apical side. So if you cut bridge restoration, this implant is removed without therapy. And then the implant placed to lingual side. Only 2 or 3 millimeter is drilled and fixed. The implant was fixed into 2 or 3 millimeter drilled side. But the bone quality is dense. So implant ITB was over 40 Newton centimeter. So we can connect early loading. Within this, without, if the bone quality is low, without bone remodeling, so we can remove overtalk with anti-clock rotation. So we can use overtalk counterclockwise turning with this instrument. So at first, connector screw is screwing into implant, and then second ratchet capture is connected, and then counterclockwise overtalk turning adaptive. So in the soft maxillary anterior case, it could be extracted with this instrument. But I recommend if 150 Newton centimeter is not enough to remove, so you have to use trephine drill. And so this instrument counterclockwise high torque could remove implant in maxilla, and then connective pedicle flap was inserted. This case is Dr. Park's case. How solve implant component problem? First, increasing the number of implant occlusal stops, so we can reduce overloading in the implant. And second, some patients have a heavy parafunctional head. So this patient have strong masset tone. So we have to use masset Botox technique for decrease force of masset muscle. And third, this patient heavy biting habit or parafunctional oral habit patient have to be use splinted restoration, and of course in off-axis and angled implant is also splinted, and of course multi-unit abutment then has to be used instead of non-precious casting bridge with a fixture connection. This is some dentist use direct casting metal framework. So this non-precious metal bridge with a fixture connection is very dangerous. So we have to use the multi-abutment. So about 30 diverse angle between implants. Change the angle with a 30-degree multi-abutment, and we can make a parallelism with a 30-degree multi-abutment, and then impress it and connect it. But you use casting metal framework, the connection between implant and casting metal is not correct, and there is no any shock absorption instrument. In the multi-abutment case, we have a cylinder and a cylinder screw. So heavy lateral force is resolved in this cylinder screw and the cylinder side. But you use direct casting between implant and metal framework. So there is no any gap between implant and metal framework. So a little discrepancy connection. This implant could be fractured or occlusal pores. So I recommend multi-abutment in the bridge, or another abutment. So direct fixture connection and bridge framework design is very dangerous. Please don't use direct casting technique in bridge. Single crown is okay. So here, horizontal stress is well distributed in multi-unit abutment system. Fixture connection is about 11 degrees. Multi-unit abutment have a cylinder and the cylinder screw on. So we can change this angulation between fixtures. And this system have abutment and abutment screw, or abutment and cylinder screw. So this connection have correct and stable, firm connection between abutment and the fixture, not connection between restoration to fixture. So this component absorb lateral force during occlusion. So we can protect implant fracture. How remove the fractured screw and abutment? We have to use multi-functional removal kit. Abutment remove is used or tapered reverse direction thread type ratchet drive. Fractured side is fractured hole of abutment is connected with abutment remover ratchet. Counterclockwise torque is make cold welding between fractured abutment and abutment remove. So we can remove with buckling wall tilting force. So we can disconnect a cold welding between fixture and abutment. And after disconnection between these, we can pull out this fracture abutment. Here, remove the fragment of abutment. And if one body abutment is fractured in the top of a picture, we cannot use the internal hole because this abutment is one body. So we have to make the slot depression with a number 330 fixture bar. And fixture bar's blade depth is about 2.5 millimeter. So we have to insert 2.5 millimeter depth for the slot depression. And then slot driver is inserted into deep slot depression. And counterclockwise latchet pores will remove this fragment like this. 330 fixture bar with a high speed, and the bar is inserted. And depth is 2.5, and slot driver latchet and remove. Screw abutment is fractured with abutment. And first, we have to remove abutment fragment, abutment remove, and then insert a guide, and the holder is connected, and Teflon drill is used with the reverse counterclockwise direction drill. At first, Teflon drill is used and then removed. Teflon drill was pegged. The next step is reverse drill. Reverse drill is used with 800 RPM or 1200 RPM with the reverse direction. And then this hole is connected with reverse drill screw remove with 20 RPM. And this screw remover is cold welded into hole of a screw, and remover turn is the screw is unscrewed, so we can remove. And here case the screw fragment is positioned deep thread, and this guide and here remove the screw fragment is shown. I will and abutment is removed, and screw fragment is positioned deep side of a thread, and guided is adapted, and reverse drill with a 1000 RPM. So we have to use a pulsed water syringe, and then screw remove with a reverse mode. 20 RPM is adapted into hole of screw fragment, and cold welded and removed. Here, fragment is removed. So we have the diameter 1.6 screw and the diameter 2 millimeter screw and 2.5 millimeter screw. So you have to check your screw diameter. But conventionally, our implant have a diameter 2 millimeter. So the screw reverse drill sequence is first 0.8 and then 1.2 diameter drill. And diameter 2.5 millimeter screw removal first 0.5 millimeter drill and then 1.2 drill and finally 1.4 drill is recommended. And eye guide and guide hold is used in the implant. So first this eye guide is inserted here. Hexagon have to be matched between a guide hexagon and fixture hexagon. And then the guide holder is adapted into a guide, and you have to keep this orientation. So slightly you have to torque two sides, and you can fix position of hold and guide. And then you have to do drill. The holder force is looser, this direction could be changed. So you have to keep this hold orientation. And then screw reverse drill is inserted into hole like this. Eye guide is inserted and hexagon is matched. And then the guide hole is a fixed component with a slightly torque force. Reverse drill is inserted and compressive water irrigation. And drilled with a 800 RPM reverse mode. Bone particle is rinsed out, titanium particle of screw. And then screw remove with a reverse mode, 20 RPM. Screw it out. And here. Screw is fixed and removed with a screw remove. Thank you for your attention. There is no failure with the implants. There is only replacement.